Good morning, everyone. We're so pleased that you joined us this morning. It is a pleasure to have you with us. My name is Deb Dillingham. I am the Senior Director for Community Partnerships here with the American Cancer Society. We asked this morning, if you've called in from a phone line, that you please enter your name and your organization in the Q&A so we have record of your attendance. All lines will be muted during today's presentation, and we ask that you enter your questions into the Q&A tab on the screen. We will be taking questions during our panel discussion, and we'll answer them at the end as time permits. If we do not have time to answer your question, just know that we will follow up with you after today's presentation. Welcome. We're glad you joined us today. And we want to start off with something we will do during today's presentation, and that is a poll question. So you'll see it pop up on your screen. And if you will, please take a moment to let us know what sector or role do you represent. And just to our producers, I'm not seeing the poll pop up. There we go. Perfect. Thank you so much. So if you can see the poll pop up on your screen, what role or sector as it relates to cervical cancer? You may make multiple choices to this, as you may be a part of a couple things. So please make your selection, and you'll see the submit button. If you will please hit submit, and then we will move on in our program. So before we begin our program, we would really like to recognize our generous sponsor. Without the support of The Ohio State University, this program would not be possible. Thank you so much to the Ohio Partners for Cancer Control, Mountains of Hope Comprehensive Cancer Coalition, and the Michigan Cancer Prevention Task Force for their continued support of this forum. Let's take a look at our agenda this morning. Thank you so much. Let's review this just really quickly so you'll know what you're in for today, which is going to be a jam-packed, wonderful presentation. We're going to begin this morning with a speaker from the Survivor organization. Next, we'll move into our keynote speaker for this morning, which will be Dr. Haley Thompson. Then we'll have a panel discussion, which will be rich and well-rounded with our presenters on cervical cancer and health equity. Next, it's followed by our best practice presentations, and then our final speaker will be from the National Roundtable on Cervical Cancer. So that's what's in store for you this morning. And let me tell you just a couple of things about the CEs. If we can go to the next slide. Perfect, thank you. The AAFP has reviewed Health Equity in Cancer Care Virtual Series Cervical Cancer webinar and deemed it acceptable for up to 2.0 Enduring Materials Self-Study AAFP prescribed credits. You will receive certificate to claim your CEs within 2 weeks following the post-event survey. Our objectives for today's event can be seen on the current slide, if you'll take a look at those. Please note that the planning committee members and speakers have declared that there are no relative financial arrangements or affiliation with the organization that may affect balance, independency, objectivity, or scientific rigor for the CE event. Also, please know that slides will be available after the presentation and that this event is being recorded. So let's stretch the muscle we have just learned, and let's do another poll question. If our producers will pop that poll up, we will ask you, how confident are you with your knowledge of cervical cancer screening guidelines? Please give us an indication of what your confidence level is as we begin today's program. We're hoping to increase that by the time we get to the end of the program. So if you'll make your selection and hit the submit button, we'll give you just a moment to do that. And while you're finishing up, let me introduce our first speaker this morning. It's my pleasure to introduce to you Kimberly Williams. Kimberly is a recurrent cervical cancer survivor. She is the patient advocate and Chief Diversity, Equity, and Inclusion Officer at Survivor. Kimberly is a social services worker from the greater Houston, Texas area with over 20 years of experience in the social services field as a social services worker, mentor, manager, and director, emphasizing the fair treatment, work ethic, and services provided to individuals with intellectual disabilities and related conditions. Kimberly has a bachelor's degree in criminal justice law enforcement and a master's degree in management and a master's degree of healthcare management. Through this experience and work with diverse populations, she works to reduce inequality gaps, ensure fair treatment, and appropriate follow-up and access to care. Kimberly, we're so pleased you joined us this morning. I'll turn it over to you.
Thank you so much. Thank you so much. I appreciate that warm welcome this morning. So again, my name is Kimberly. You have given all those great accolades, and I appreciate you for that. Next slide. So I'm just going to tell a little bit about how I got started in this cervical cancer journey. As previously stated, I was a mom, I was a wife, a full-time director for an organization, and then life hit me with cervical cancer. In 2018, I was diagnosed with 1B2. I had a radical hysterectomy, and initially my physician said, hey, everything is fine, everything is going to be good, no worries. I went in, I had the radical hysterectomy, and they found some cancerous cells on the outside of my cervix. With that being the case, they wanted me to have some preventative radiation and chemo treatment. However, my insurance would not pay for an additional scan for me to go ahead and have the radiation, because they wanted to know exactly where those cancerous cells may be. So it took a year for me to be able to get one scan. So April of 2019, I was able to get one scan approved. I got the scan in May of 2019, and that's when I found out I had a recurrence and the cancer was on the other side of my body, and I was staged at 3. So at that time, went through all the not only the staging, but just figuring out what was going to go on in these next steps. It's very hard for someone that has been a director and you're running things, and now you're having to go on what these physicians are actually telling you. What is your next step? So I dropped my children off at school. I'll never forget this. August 25th, 2019. I dropped my kids off at school, and then I went to go have my first chemo and radiation treatment. It was something that I had to learn. I had to learn to educate myself on what was actually happening with my body, because of course I was very scared. I found Survivor right after my radical hysterectomy, and that's what led me to a lot of information and watching and seeing how people navigated through this time. In October of 2019, I rang the bell for the conclusion of my chemo treatment and also for radiation. In December of 2019, I had my first no evidence of disease. Next slide. So I found my voice. I found that this was something that I am very passionate about, something that I felt that I believed that if I use my voice, especially in diverse populations, that I could make a difference. I could talk to someone and they would understand, and they would see like, wait a minute, this happened to someone that looked like me. I realized that I never heard anyone say cervical cancer. I never heard it before. So because I never heard cervical cancer, I thought that I literally was the only one in the whole world that had cervical cancer, until I saw Survivor and I saw that it was other people that had cervical cancer. I was like, wow, I need to utilize my voice. So as you see on this slide, I've been utilizing my voice not only for panels, but I've done tabling events, I've spoke at events, I've done American Cancer Roundtable where I've told my story, and I've also done podcasts as well. So it's just a way to share my story and to make sure that other people understand and know about cervical cancer. Next slide. And this is just a little bit about Survivor. And Survivor is a global community and a global community of patient advocates who inspire and empower those affected by cervical cancer. And we're educating and motivating them to use their voices to create awareness and to end stigma, influence decision and change, and end cervical cancer. Next slide. And this is how we move as Survivor to close the disparity gap, because we do realize that how many women are affected, or those with the cervix are affected by this disease each year. And so as we work together, we realize that Black women are more likely to die of cervical cancer than any other ethnic group. And our Latina and Hispanic women have one of the highest rates of cervical cancer and the second highest rates of death related to cervical cancer. So we at Survivor understand the disparity gap, and we're working diligently to close that disparity gap. Next slide. And this is how we're addressing those cancer disparities. We're working in our communities to increase screening rates. And by encouraging HPV vaccination, we're hoping that we can see a difference in our communities and with cervical cancer and the rates that cervical cancer are at this time. And encouraging clinical trial participation, because we do realize that a lot of people that are diagnosed with cervical cancer have not been offered clinical trials. Clinical trials were not offered to me. And so this is letting them know that they're safe and that they should be offered those clinical trials. Next slide. And this is just a way for you to be able to get in contact with Survivor if you have any questions, any person that you know that has cervical cancer and they need to be connected with someone. We're on all social media forums, so you can definitely platforms, so you definitely can get in contact with us in that way. Next slide. And this is how you can get in contact with me. So that's my email address, Instagram and Twitter, and then also LinkedIn. That's all. So thank you so much for your time. I appreciate each one of you.
That's wonderful, Kimberly. Thank you so much for sharing your story, such a powerful story. So we appreciate it. And we hope that you'll stick around with us this morning. Great. Thank you so much.
I will, no problem.
Let's turn now to our keynote speaker for this morning, Dr. Haley Thompson. Dr. Thompson is a professor in the Department of Oncology at Wayne State University, School of Medicine, and the inaugural Associate Center Director for Community Outreach and Engagement at Karmanos Cancer Institute, an NCI-designated comprehensive cancer center. In this role, she has established KCI's Office of Cancer Health Equity and Community Engagement and serves as its founding faculty member. She is also founding director of the emerging WSU Center for Health Equity and Community Knowledge in Urban Populations, also known as CHECkup. That's a part of CDS Health's Community Equity Alliance. She's a clinical psychologist whose research addresses racial and ethnic disparities in cancer care and outcomes. Her primary focus is community-based research, including investigations of cancer survivorship. She has received funding from the National Cancer Institute, the American Cancer Society, the National Heart, Lung, and Blood Institute, the Agency for Healthcare Research and Quality, the Patient-Centered Outcomes and Research Institute, among other agencies and foundations. We're so pleased and honored that you could join us this morning, Dr. Thompson. Let me turn it over to you.
Hello, good morning, everyone. Can you hear me okay?
Good morning.
Awesome. So can you have next slide, please? So thank you to the American Cancer Society, everyone there, everyone that's part of the planning committee for today's event, for including me today. I'm really happy to be here. I'm really honored to follow Kimberly Williams, who just spoke. You know, so much of my work is about amplifying the voice of diverse community members in cancer prevention and control, and the work that we're doing in our academic institutions and our hospitals to include more of our patients and community members in these efforts. So a lot of what I'm going to talk about today is about how my team and I have leveraged data and community partnerships to try to advance cervical cancer prevention and control in the diverse communities that we serve in the state of Michigan. So I'll get started. Next slide. Okay, so I'm going to provide in these first few slides just a little bit of background information, not a whole lot. I'm going to be moving kind of quickly because I know we don't have a whole lot of time and there's a lot I want to share. But just a snapshot of cervical cancer in the United States. This is from the American Cancer Society Facts and Figures for 2023, a document that many of you know well. In 2023, over 13,000 or almost 14,000 cases of invasive cervical cancer will be diagnosed, and an estimated 4,300 women will die from the disease. Next slide, please. I want to talk a little bit about the disparities that we know exist when it comes to cervical cancer. First, I'll talk a little bit about incidence and mortality. You know, overall, about 7.7 persons in 100,000 will be diagnosed this year when it comes to cervical cancer. And we can see on the left that talks about, that's our figure for incidence, the new cases, that when you look at the bar graph, we see that we expect the incidence to be somewhat higher among Hispanic or Latino women, as well as American Indian, Alaska Native women, and Black women, right? And then when we look on the other side, when it comes to mortality, per 100,000 folks, we see that the bar is highest or longest for non-Hispanic Black women. So we're seeing, again, disparities when it comes to race and ethnicity. Next slide, please. I also want to talk about some other disparities in terms of stage of diagnosis and survival across the country. So based on some of the SEER data from the National Cancer Institute, you know, so on the left, the graph shows stage of diagnosis per 100,000 people. And if you look at the red and the blue bars, those bars represent more advanced disease. And again, we see differences across race and ethnicity, with those red and blue bars being longer for Hispanic women as well as for Black women compared to white women. And on the right, we have 5-year survival rates. So once women are diagnosed, how long are women surviving and living after being diagnosed with cervical cancer? And we see those survival rates for Black women tend to be lower, and significantly lower actually, compared to women of other groups. So, you know, as we look at some of these disparities, they start to give us a little clue about potential areas of focus when it comes to intervention. And certainly, you know, one area that many of us focus on is screening. Right, so let's go to the next slide, please. Oh, so let me talk, actually, before I go and talk about screening, I want to kind of bring this back to sort of my own work and make it a little bit more local. So I shared with you some national statistics, but part of my job as Associate Center Director for Community Outreach and Engagement at Hermanos Cancer Institute is to monitor cancer burden in our catchment area, right? So I want to just talk a little bit about what is our catchment area in Michigan. It includes 46 counties out of the 83 in the state, and these 43 counties are home to 6.7 million people. And we have 15 cancer care sites across the state of Michigan. And those counties within our catchment area are home to 95% of the patients that are treated at our sites. And in fact, Hermanos Cancer Institute treats about 1/3 of new cancer cases in the catchment area. So in terms of key characteristics of our catchment area, which is kind of important to some of the work I'll talk about today, our catchment area includes the city of Detroit, which is the largest city in the state. And it's notable in that it's about 78% African-American, and about over 1/3 of the population live in poverty. What's also notable about our catchment area and our state in general is our population of Arab American and Middle Eastern North African individuals. There's over 250,000 people of Arab or MENA descent living in the state, and are represented strongly in our catchment area, particularly in the Southeast region. We have 725,000 rural residents, and then about 4% of our population identify as sexual and gender minorities. So that just starts to scratch the surface in terms of the diversity of our catchment area and kind of the groups risks that we want to pay attention to when it comes to cervical cancer prevention and control. Next slide. So I'm going to share with you some of the data from our catchment area, because it starts to then reveal some trends and areas that we want to pay attention to as we strategize around solutions for around cervical cancer disparities. So if you look on the right here in this bar graph, I apologize that for incidence, our clean data for Detroit was not yet available. But what you're seeing kind of moving from left to right is are the incidence rates for the city of Detroit, but then our Southeast region, East region, Central and North region. And so you can see here with incidence, if you look in the middle here, the green and kind of grayish blue bars, we can see that in the central and northern region, incidence is somewhat higher compared to the state and some of the other regions, right? And those tend to be some of our more rural areas. We have kind of fewer metropolitan areas and in those regions. So that's something to pay attention to in terms of our rural populations and cervical cancer. And then if you move over to the right, there we do have mortality data for the city of Detroit. And you can see it's higher compared to some of the other regions, but it's also higher in the northern region, again, a more rural region. So these data are really important in terms of helping us to think about and strategize and plan our efforts and our interventions. And within most of these regions, we have started to look at racial and ethnic differences. And certainly within most of the regions, as well as the catchment area as a whole, cervical cancer incidence and cervical cancer mortality are higher among African Americans compared to whites. So that is a trend that we continue to see in our catchment area that mirrors what's happening nationally. Next slide. So as we think about some of the disparities that I've reviewed, particularly when it comes to stage of diagnosis and mortality and survival, you know, a lot of the effort of our team, as well as I know many of you, has been focused on cervical cancer screening, specifically Pap test and HPV testing. So I wanted to share, at least for Michigan, what the screening rates reveal at least as of 2020. So these data come from the Michigan Behavioral Risk Factor Survey. And the most recent data that we could obtain was from 2020. And in fact, in the state of Michigan as a whole, you know, almost 69% of women report appropriately timed Pap test, because those time periods do change based on age. And which is interesting, in that we are not able to kind of get more granular data for our catchment area regions, but data suggests that in our catchment area specifically, the screening rates of when it comes to Pap test are similar or even higher. However, all that needs to be taken with a grain of salt, because all cancer screening rates have been muted somewhat and are likely lower due to the pandemic. And there's a lot of people who are due for a range of screening. So I kind of take this with a grain of salt. But it's interesting to note that 68.7% is not very far off from some of the targets that we hear about from different organizations, such as Healthy People 2030, which has a target of having 80% of women being appropriately screened for cervical cancer. But again, we kind of take this with a grain of salt, and it can differ across regions and different areas. Again, I have here just looking at some of these racial and ethnic differences, and at least in Michigan, the rates are similar. They're not too far off. And in fact, for Hispanic and Black women, Pap test rates are higher. At least, again, as of the 2020 Behavioral Risk Factor Survey, which is kind of interesting to note, and that does represent a change over time. However, we still see sociodemographic differences and differences across insurance status as well. You can see here on the right, kind of this jump from when you go from lower, the bars on the left represent lower income groups, and they really jumps up quite a bit when you get to higher income groups. So socioeconomic disparities are still really important to pay attention to. Next slide. So I want to just share some of our early work of my team when it comes to increasing cervical cancer screening. So this is work that we conducted between 2012 and 2019. So it's work that kind of ebbed and flowed over those years. But we were part of a national model, a national network called the Witness Project. Some of you may know of it because it's a very pretty well known and robust intervention to increase breast and cervical cancer screening, specifically among African American women. women. And I've worked with it. I used to work and live in New York, so I helped found witness projects there. And when I came and moved to Detroit in 2011, I worked with others to start the witness project in Detroit, and that evolved into a similar program called Real Talk, right? So what did we do? We trained Black women in the community as lay health advisors who would then go into different community-based settings, mostly churches, but we went to WIC centers, we went anywhere we were invited. And these women, along with our team, offered an educational session and taught other Black women about breast and cervical cancer screening. So we also offered navigation services in partnership with our breast and cervical cancer navigation program. And over those years, we reached over 2,000 women. We collected different metrics. And in terms of at least knowledge, we showed increases in breast and cervical cancer knowledge and an increase in the rejection of certainly breast cancer myths and cancer myths in general, frankly. So this was something that was a very powerful piece of what we did. Again, and just going back to Ms. Williams, we had a key part of this was a key part were the survivors who were lay health advisors who shared their personal stories of diagnosis and survival. And frankly, I will say this, if we offered a lot of information and people learned a lot in terms of all the risk factors and screening guidelines, but without a doubt, the most powerful part of every presentation was the survivor story and the survivor narrative. And that changed a lot of hearts and minds and behaviors, just hearing those stories and hearing those experiences. So this was a really important part of the work that we did, working with communities, groups like Sisters Network and others, to extend our cervical cancer outreach. Next slide. So what was interesting though, even, at least in the earlier days, even as we were talking about cervical cancer screening, we didn't talk a lot about HPV vaccination as a part of prevention. So, and some of that had to do with our volunteers, right? It was kind of difficult nationally and locally. Some of our volunteers were very hesitant about sharing information about HPV vaccination at the time, because they didn't know it, they didn't trust it, they weren't certain about it, didn't have information about it. So it took a while for the program and the model to integrate HPV vaccination information into our work in the community. And we actually at Carmanos started to develop that content at an earlier stage and started to integrate into our work. And a lot of what we created, we then shared. These are some slides from those earlier days that we actually started to share with the national program to start teaching, again, our lay health advisors to share this work with the community. So you can see we have information about HPV facts and its connection to cervical cancer and the vaccine and what the recommendations are. So this was something we started to do early, but it took time. And so that's something to be conscious of, that kind of hesitancy and mistrust in the community, particularly when we're talking about African-American, some African-American populations. Next slide. And I just want to review the ACS's HPV vaccination guidelines really, really quickly. Many of you know HPV vaccination is recommended starting at age 11 or 12, can be as early as 9, and it's recommended for persons through age 26 if they're not adequately vaccinated. And our Healthy People 2030 goal is to have at least 80% of age-eligible adolescents get the recommended doses or receive the recommended doses of the HPV vaccine. Just to bring it back locally, Michigan ranks 20th among the states in terms of the proportion of adolescents who have received our recommended doses. So we're kind of in the middle when it comes to all the states nationwide. And in our catchment area specifically, those 46 counties, our rates really, they vary widely from 30 to 60% throughout the catchment area. And a lot of it in some of, again, more of our rural areas, we're seeing some lower rates. So next slide. So I want to kind of then move on to some informative work that we started doing as we began to move from the Witness Project to other work that focused more specifically on HPV vaccination. So this is some formative work that was conducted a few years ago, some focus groups that actually my team and I conducted, and I have a really wonderful postdoctoral fellow working with me now, Dr. Ariel Washington, who actually did some deeper analysis. And this is in press now. Why is it so necessary? African-American parents' perspectives on delaying and refusing HPV vaccination. We conducted 3 focus groups in Detroit, Inkster, which is a town that's adjacent to Detroit, and Flint. Primarily, we worked with African-American parents and caregivers who either delayed or refused HPV vaccination even after it was recommended or discussed with a healthcare provider. We wanted to kind of talk to, again, the people who were most resistant, who were most hesitant. Next slide. just to give you an overview of the finding, because this is all starting to build up our next steps. Dr. Washington and the team and I, we looked at, we identified contextual influences, and that's really important to pay attention to, right? On the left, perceived discrimination based on race, as well as insurance status and income. That came up in our groups. Medical mistrust broadly. This is an interesting one. It concerns about Black children being over-sexualized. One of our, I recall one of our focus group members talked about bringing her daughter into the doctor and having the doctor keep saying, you know, you need to get your child vaccinated. You need to get your child vaccinated. And she was very resistant about it, saying, my child's only 9, my child's only 10. You know, she's connecting with sexually transmitted infection. She's like, well, my daughter's not having sex. Why do we need to do this? And the physician communication around this wasn't clear. And this is tied into just long history of stereotypes about Black people being hypersexual, right? And concerns that this doctor was kind of trying to sexualize or over-sexualize her child. You know, so important kinds of information we get when we kind of talk with the groups that are most resistant and get more specific. Also, individual and group influences were noted. Low quality communication with providers is notable there. And then when you look to vaccine specific influences, going back to that witness project model, right? Survivors sharing information, or people who've experienced some a situation sharing information. That second point, desires for testimonials from individuals for whom a substantial amount of time has passed since initial vaccination, right? They want to understand, you know, what are the long-term effects? That, you know, people wanted more clarity around that and wanted to talk to people who had vaccinated their children, people like them. So next slide. So, you know, this moves us to then that we then had an opportunity to apply for funding from the National Cancer Institute to advance and do more of this work in cervical cancer. We received funding both in 2019 and 2021 that allowed us to become part of the NCI's National Outreach Network, or NON, N-O-N. And what they asked our cancer center and other cancer centers to do was to take their existing NCI materials and which was just really just a PowerPoint, and say, hey, adapt it, tailor it to your community, and disseminate it. So we worked with this PowerPoint and we worked on adaptation along with our community partners. As I said in the beginning, we try to do as much as we can in partnership with our communities. So for our particular focus, we included, or we had a particular focus on Metro Detroit's African-American populations. We wanted to build upon the Witness Project and Real Talk and build a program where we, again, trained people and women from the community to teach other folks about HPV vaccination. So we worked with a community partner, a really strong longtime community partner, Detroit Parent Network, and their parent advocates to adapt the PowerPoint we received from the National Cancer Institute. And so we met over several occasions to kind of work on this PowerPoint, and it resulted in what we call Project ACE, Advocates for Cancer Education. We developed training materials so that we could, again, train women, train parents, any parent, to be an advocate and teach other parents and other people about HPV vaccination. And so they would become ACE leaders. And by February 2020, we actually had 7 parent advocates who completed this ACE leader training. So we're ready to go. But you can see by the date, you can probably guess what's going to happen, right? Next slide. Right. So March, we all were, staying home. So we had planned these, for this program to be in person with group sessions, to be very dynamic. But, again, this wasn't possible because of the pandemic. So we pivoted. We first converted then our session to a narrated and recorded PowerPoint presentation. So I'm going to call that our basic video, because you can record a PowerPoint and present it as a video. And then we were able to involve some additional partners to Detroit Parent Network. We included a group called Involve Dad, that's based out in Flint. We included Western Wayne Family Health Centers and their location in Inkster, right? And then we were able to get funds to then update the video. And so it became something that was more professionally produced and dynamic. I'm going to call that our enhanced video. Next slide, please. So just to talk about what's in these videos, right? So you can see some of the images here on the side. Project ACE, that's our logo. Camille Hope Irvin is one of our parents who talked about her experiences with HPV and cervical cancer. And those are her daughters. And she talks about vaccinating, having them vaccinated and protected. Dr. Jonathan Heckman is from Western Wayne Family Health Centers, our community clinic, who talks about the importance of vaccination. The video components, we include testimonials, right, from parent advocates. We talk about HPV in Michigan, HPV and cancer in general. We talk about cervical cancer in American women. Sorry for the misspelling there. Any place where there's an asterisk, that is actually the suggestion of our community members, of our parents. That is their input. A focus on head and neck cancers, because that then ties it more closely to boys and men, our parents wanted to see more about that. So we can, and last I point there to the last point, myths about the HPV vaccine. They thought it was really important we include information around that. And we actually ended up with 2 videos. We have one that's more targeted and tailored for African Americans, and we have one that's more multicultural. So I want to talk a little bit about our experiences there. Next slide, please. So we presented those videos, both the basic and enhanced version, as parts of webinars and group sessions. We had a pre-test and a post-test that people took right before and after the video, along with a 3-month and 6-month follow-up. We did use assessments. We had to use assessments that were provided by the National Cancer Institute's National Outreach Network. So we're kind of limited in that way. But those assessments did include 19 knowledge items, were just true-false responses. You can see some examples of those items there. And also we had some items around intention. What do you plan to do now that you've seen the video? What was your intention before and what was your intention after the video? And a couple of questions there. I'm likely to have my children vaccinated against HPV. I'm likely to speak with my children's doctor about HPV, the HPV vaccine. Next slide, please. So I'm coming to the end. So right now we have, it's been kind of more difficult doing it kind of online as part of webinars versus doing things in person, but just I'm kind of wind it down. We had 65 people so far. We're still, I'll talk a little bit about what we're doing with the video now. About 78% saw the basic video, 22% saw the enhanced video. Mean age was about early 40s. More women versus men were participating, and the majority identified as African American. Next slide. So we also asked people, obviously, people about questions about their children. Now, our eligibility criteria was we were including parents who had children between the ages of 11 and 17, with kind of the assumption that they're making healthcare decisions like vaccination for their child. But we did ask, as part of the NCI requirements, about all the children they had between the ages of 9 and 26 years. So this is what you're seeing here in terms of the distribution, with most people having either 2 or 3 children. Next slide. Or more than 3 children. And then here we have the proportion of participants who reported having vaccinated children. So you can see 46% had none of their children, age-eligible children, were vaccinated, right? And then on the other side, you see that 31% had all of their children vaccinated, 100% of children vaccinated. Next slide. So in terms of our knowledge findings, it was kind of interesting as we were kind of, and these are preliminary findings, but you can see when we look at all participants, regardless of the video, we see an increase, at least in their knowledge, from 66% correct to about 78% correct. That's an 18.5% increase. But what's interesting here, and I didn't expect this necessarily, when you look at the basic video, it's very similar to what you see across all participants. But the enhanced video, we see actually a larger increase in knowledge, right? So we're almost a 24% increase. So kind of gives us an idea of what we kind of know. The medium is important, right? How you deliver the message, it can make a difference. It can make a big difference. Next slide. And in terms of intention, we're really pleased. These are only with the parents who had fewer than all of their children vaccinated. So parents who had some unvaccinated children. When you look at the question, I'm likely to have my children vaccinated against HPV, we see an increase, right, in those who strongly agree or agree at pre-test to post-test, from 44% to about 58%. So, you know, this gives us some early kind of idea that we may be able to move the needle with these kinds of strategies. And also we saw a smaller increase in terms of likelihood of speaking to one's doctor or your child's doctor about the HPV vaccine, but it was also starting off at a higher proportion of those who agree or those who agree. Next slide. So in terms of ongoing work and strategies, just reflecting kind of our catchment area opportunities and building upon what we were doing, there's so much more to be done. But, you know, I'm hoping that we have a foundation that can kind of move us forward in a really effective way. We want to really return to the original, now that we're at a different stage of the pandemic or the end of the pandemic, return to the original Project ACE plan so we can go ahead and retrain our lay health advisors as cervical cancer educators who are active in a community and doing in-person outreach and education. We certainly have tremendous opportunities for targeted adaptation for other populations, our rural populations, our MENA populations, our LGBTQ populations. So we can continue to do tailoring of the video. We certainly want to disseminate, and we're working right now on dissemination of Project ACE video in primary care clinics and FQHCs and managed care plans as well. Right now, we're planning with Western Wayne, our partner, to text the parents of age-eligible unvaccinated children a link to the video. And then because hopefully because they're already in their EMR, we should be able to do some tracking about actual vaccine uptake. And finally, you know, a huge piece of this, so much of our work, next slide, is focused on our community and working with with individuals on a grassroots level. If you can go to the next slide, please. I think there's two more. We really need to focus on multi-level intervention and more focus on systems, and that has been kind of definitely a more challenging piece for us. We are right now trying to develop new partnerships with clinics so that we can actually start to work with healthcare providers and support the provider recommendation, which is really key and really essential to kind of increasing those vaccination rates, in addition to an individual or patient or family level focus through the video. You know, one of the things you might notice is Carmanos is part, it's been almost 10 years, but we're part of the McLaren healthcare system, which is a fairly large healthcare system here in Michigan. And so we've been trying for a couple of years to move through and work with the physicians, particularly those who work with the pediatric populations in McLaren. And the level of system complexity is really kind of, it was more than we would have ever expected in terms of the doctors who see children and adolescents who are affiliated with the hospital, employed by the hospital, or who just have privileges there. We have, there are docs who are connected with our healthcare system who are independent, and they don't store any vaccines in their offices. They kind of refer their patients out to the health department or to Walgreens. So tracking is going to be really, really a challenge when we kind of do more within even our own healthcare system. So and I know many people are facing those similar challenges. So that's where I'll end. Thank you very much for your time. And thank you to everybody who helped make this work possible. Thank you.
Dr. Thompson, thank you so much for all that you shared this morning. We certainly do appreciate it. And we ask that you'll stick around for our panel discussion later, if that's okay.
Thank you. Absolutely.
Wonderful. We appreciate it. Thanks so much. So let's move on in our morning today. Next up would be our panel presentation hosted by Chesley Cheatham. One note I want to make about our panel presentation is just this morning, as flexibility is always the name of the game, we will do a quick pivot due to one of our presenters who is not able to join us last minute, sending obviously their regrets. But fortunately, we have Kimberly Williams that has agreed to stay with us and join our panel. So win-win for us. Let me introduce our panel moderator. Chesley Cheatham serves as Director of Community Outreach and Engagement, Health Equity DEI at University Hospital Seidman Cancer Center in Cleveland, Ohio. Chesley spent her undergraduate years at Sam Houston State University in Texas and earned her master's degree in education at the University of Houston, where she became interested in the area of health literacy. In her previous role at the University of Texas MD Anderson Cancer Center, she worked in patient education office and was responsible for the design, development, implementation, and evaluation of patient education programming. She has secured funding and collaborated with community partners in Northeast Ohio to address cancer screening inequities with underserved and vulnerable populations. It is her hope that subsequent programs will improve access to care, increase cancer prevention measures, and establish sustainable partnerships that will result in lower cancer incidences. It is so much our pleasure to have you with us this morning. I will turn the panel over to you, Chesley.
Thank you so much, Deb, and thank you to the American Cancer Society and the planners of this particular program for really bringing the awareness of equity around cervical cancer. It's hugely important, and my pleasure to be a part of it. And thank you to the panelists. So again, I think specifically Kim Williams, who's got a pinch hit. Dr. Gordon, of course, couldn't be with us today. But just a quick, I'd like to introduce a few folks, and so making sure that we have our sound there. Dr. Laura Chambers of The Ohio State University, might you introduce yourself?
Of course. So I'm Laura Chambers. I am a GYN oncologist at The Ohio State University. So in my clinical practice, I take care of women with cervical cancer, provide them with surgical treatment, and then also chemotherapy and survivorship care as well. I also do research looking at cervical cancer, and also I'm really interested in microbiome research, but I am thrilled to be here today. This is a really important topic, and I'm looking forward to talking more about this with you all.
Indeed, thank you so much. And to our other panelists, Olivia Thomas, might you introduce yourself as well?
Sure. Hi, everyone. My name is Olivia Thomas. Thank you so much for everyone organizing this. I'm so excited to be here. I just received my Master of Public Health from Case Western Reserve University, where I completed my master's thesis in identifying the barriers to cervical cancer screening in eligible Hispanic women in Cleveland. I worked closely with the Metro Health system, which is a large public hospital system in Cleveland, to look at these barriers through a mixed methods analysis using quantitative and qualitative data. Furthermore, I'm also working with Metro Health on a pilot project to examine the efficacy of preference between at-home cervical cancer screenings versus in-office. So I'm really excited to be here and talk with you all today.
Thank you for that. And a huge welcome back to Dr. Thompson and Kim Williams. So thanks for being a part of the panel. And just for context, I'm located in the sunny but now hazy area of Cleveland, Ohio. And thank you, Ms. Thomas, for just giving us a little bit of breadth about some of the sort of healthcare systems here in Northeast Ohio. And I think a lot of us probably come from areas that have multiple healthcare systems. So just to get started, this is Pride Month. June is Pride Month. And as we sort of recognize and celebrate our colleagues, friends, families, and patients who come from LGBTQIA plus communities, I wanted to just start out with just a question around the impact of language around screening. And I'm just going to throw this to Dr. Thompson, initially. Can you tell us a little bit about what that means when we talk about language and screening, and more particularly when we say talking about women versus using language that says people with a cervix?
Yeah, thank you so much for that question, because this language, and I can certainly even point to myself. It's really important that we get consistent about kind of the language we're using, because as we move towards equity in care, we need a big part of this is inclusion, right? As we think about DEI, inclusion is a big piece of this. So it's really striking that right now there's a strong movement around cancer centers and comprehensive cancer centers right now to really be more deliberate and intentional around the language they use as we collect data about our patients, and how are we asking questions about sexual orientation and gender identity, those SOGI questions. And this is aligned with it, right? Because even as we ask even putting these questions about identity on a piece of paper, a lot of training has to go along with that, right? We can't just ask these questions. We have to prepare our staff, our providers, our patients for the fact that, that we're starting to ask these questions. And I think along with that, that's kind of another phase, right? Is then, how do we then become more conscious and consistent about the language we use to describe people and issues around gender and identity and body parts and who is eligible and who do we need to talk to about certain screenings. So that's where I'll start the conversation.
Well, that's perfect. And feel free, anybody else, to sort of add into that as well.
Yeah, I was just going to say, I think, our words really, really matter, what we say. And especially when it comes to something as simple as screening, for a patient to come in for a screening test, there can be many barriers to that. But I think that the decision to come in for screening is in many times it's an intentional choice that someone has to make. And if we make the environment to come in for screening that's, people feel like we communicate accurately, that we're respectful, I feel like we welcome people to come in to that environment. Whereas if people feel like they're not listened to, or they're not welcome, or people don't look like them, or their choices are not respected, then they're not going to want to come, and I think that that's really important, is we have to create these environments where people feel that they're welcome and that they can get the care that they deserve.
Agreed.
Yeah.
Anyone?
Can I just add to that? I'll just share, and I don't think I'm speaking out of turn. So, because, one of my close colleagues who work with our Office of Cancer Health Equity is a transgender man and has given presentations on this topic to our Michigan Cancer Consortium and in other areas, because he is a man but has a cervix. And he really gave a presentation with a very personal account of how much he hated going to see the gynecologist, right? Because of all that he would encounter in terms of names and, pronouns and that sort of thing. So, those kinds of factors are going to play a role in disparities, and that's part of collecting these SOGI data, is about kind of really getting accurate information and reliable information about trends when it comes to LGBTQ populations. But I think as we do that, we're going to see, I think those kind of trends are going to emerge. We're going to continue to see those disparities and lower use of certain services because of these types of issues.
Yeah.
interesting in terms of what could happen with lower use. I just want to follow up around a question around technology. And as we become more reliant on electronic EMRs, et cetera, Dr. Chambers, I'm going to throw this one to you. Can you chat a little bit about what role technology plays in improving cervical cancer outcomes and promoting that around health equity?
Yeah, I mean, I think that this is such an exciting space. I think there's just a lot to do. And I think it's probably like not individualized, like it's an individualized approach to certain populations. I mean, I just think it's limitless. I think, knowing that we're using electronic medical records, knowing that those medical records can communicate, I think it's also like, is it setting reminders, so people can come in. I also think that there's a big role for social media in some of these things. I'm actually really interested in this, and I've done some research looking at what patients are posting and their values on TikTok and on Instagram. And, I think that in that research that we did, we actually looked at like the quality of educational content that's out there for patients, and it's really poor. And so I think that we really have a responsibility to like educate people, help people find good quality health information, and make it relevant to them as well. And so, I think that one of the hard things is there's a lot of barriers there, right? We're all busy. So going home after a busy day in clinic and then creating TikTok content isn't like on the top priorities of things to do. But,
Right.
I think that when I talk to many of my patients, like that's where they're going for their information now. And I think that it's really important. So, I think social media, I think that is a big thing. I think, the electronic medical records and being able to send people reminders. And I think it's really great that we're giving people access to all their medical information. And so it's really transparent what's going on. But yeah, I'd love to hear other people's thoughts and ideas on that too.
I was just gonna say real quick, I wanted to jump in there because one of the things with Survivor, the heartbeat of our organization is social media, because people are looking for content, and we pull content from different places, especially too. But one thing I can say as a cervical cancer survivor, that being a survivor of cervical cancer is or even getting the diagnosis of a cervical cancer is so isolating. You feel like, I mean, you heard me say, I felt like I was the only one in the world. And I know that sounds crazy, but if you've never heard the diagnosis before, because it was such a diagnosis that no one talked about. And so if no one talks about it, you think like, am I the first person in the world that got this? As you research, you see it. And so I think the more that we not only educate the patient, but also educate the provider. So when we both are educated, that is what helps us. It's like, okay, wait a minute. No, we have other people that have this. You can look at this organization. There's a whole slew of people that are understanding, and they're there for you. And so I think the more that we educate each other, that helps us in reaching more people to help end this disease.
Yeah, I totally agree. I do really commonly actually refer my patients to social media to get information. And I think that there's a real value in meeting people that are going through or have gone through what you've gone through. And I find that a lot of my patients get really good questions and things to ask me from Facebook forums and things like that they never would have otherwise, things that we're going to talk about, but maybe we haven't talked about yet. And then they bring it up and I'm like, oh, I'm so happy that you're asking me that. Like, I love that you're taking the time to educate yourself and like be in control of your healthcare. So I think that there's so much potential in that. And I'm really excited about it.
Thank you for that. And Olivia, did you want to mention? Sorry.
These are incredible points. And I think a large part of the reason why cervical cancer screening is so difficult to stay on top of is like a lot of young women don't realize that, oh, age 21, like I need to start getting pap tests. So social media is also a really great resource for teenagers and people under the age of 21 to learn about cervical cancer before they have to start getting these screenings regularly in order to for prevention. In addition, the HPV vaccine is also a huge part of cervical cancer screening. And so that is also a great part for the provider to come in and say, hey, like we need to start talking about cervical cancer and HPV vaccines, because it's not something to be uncomfortable about. It's
Mhm.
a body. Like everyone has a body. This is just something that we need to be aware of. And so due to the vulnerable nature of cervical cancer screening, I think it's really important for the providers to build a relationship with their patients that's based on comfort and safety and respect. And I think social media is a great way to start becoming comfortable about talking about these things.
I agree. Thank you for that. And, I think that education has kind of been a theme throughout many of the presentations that we've heard today. And specifically with Kim, I wanted to follow up with you. And you mentioned that you felt a bit isolated and maybe didn't know much about cervical cancer. Tell me what educational materials you would recommend for those who are initially diagnosed or just wanting to learn more about cervical cancer.
I mean, definitely. I looked at American Cancer Society now, and that was a big thing for me, because you're looking at so many different aspects, like, because it's talking about every cancer. And I think that's why I stumbled upon Survivor, because it was specific to cervical cancer.
Mhm.
And then they gave links that would, oh, okay, I can look here. I see
Mhm.
this, I see that. And it helped me to feel more powerful when I went in, and I felt like an educated patient, if that makes sense. Because
Mhm.
with my my oncologist, my chemo oncologist, it was a difficult conversation that we were having, because she felt like I should just know. And I had to tell her, listen, treat me like I'm new, because I'm very smart. I'm not
Right.
dumb,
Right.
but I don't know this. Like,
Right.
I've never
Yeah.
practiced medicine. So I
Sure.
want you to treat me like I've never had cancer before. And she looked at me like, but the thing is, what I realized going into some rooms, they just kind of assume that
Yeah.
and it's that conversation that I think is so necessary. Not just where they're going to look for information on social media, which I think is great, but we want to be able to talk to our physician and be able to get this information back. And I know it's a lot of different things. Even being a person of color, we go like, I'm in pain, and they
Right.
feel like Black women, and that's it's seen a lot. They feel like Black women can tolerate pain way more.
Sure.
No,
Sure.
help me. So
Right.
it's being able to educate patients as well, which is why I'm a patient advocate, is to educate patients to talk to the physicians and let them know, this is how I feel, this is what's different. Because we, a lot of times, especially people of color, will just
Mhm.
try to figure it out on their own, the home remedies. We're gonna figure this out.
Mhm.
I'm gonna lay down. I'm gonna
Mhm.
no, let them know you got chemo in your body, you're dealing with radiation. Let
Mhm.
them know, like, I got a little heartburn. What is that about? Like, I didn't have that before.
Right.
Because if we don't, then that's where you end up exasperating some of those issues that were never brought to the
Mhm.
physician. And then the physician is like, well, why didn't you say nothing? So
Yeah.
it's those type of things that I think sometimes talking to another patient
Mhm.
actually assists.
Right.
Hopefully I answered your question. I
No, you did
went on my own little
beautifully.
tangent there.
No, but that it's all relevant. And I just want to say, just in terms of education, I wonder if, and then I'll sort of full disclosure, if we should be including anatomy, just in general education around cervical cancer. I couldn't tell you if I knew the difference between my uterus and cervix when I was 21, truly. And I wonder if that is a bit of a barrier. And Dr. Chambers and Olivia, or anyone, if you could speak about that, if you include anatomy and just sort of just structural things when you educate your patients around that.
Yeah, so I completely agree. I think there's two things. The anatomy piece is huge. I mean, I think that, why would you know those things? I mean, unless you have to be taught. Like, I wouldn't have known those things unless I had been taught, and I think we make a lot of assumptions about what people are taught about their bodies and their sexual health. And we know that kind of across the board, we're probably not getting what people need. So as part of my, like when I meet a patient in the office when they have come to me with a cancer diagnosis, I always joke that I went to medical school, not art school, but I actually, every single new patient, take a piece of paper and draw out their parts. Like I draw, this is your uterus and this is your cervix and these are your ovaries, because most people don't know, and why would they? Like
Yeah.
if no one's ever taught you that. And then I always actually offer people to take that drawing home, and many of them do. And like we kind of make a joke about it going on the fridge, but I think that it's helpful for people to know, to understand. And I do talk about that. Because I think there's a lot of nuances there with understanding your anatomy, and then what treatment am I having? Like if I'm having a hysterectomy, what's happening with my ovaries? Do my ovaries come out? If I'm having my hysterectomy, is my cervix staying? Like there's just a lot there that people really need to understand. And you know, I think that they are our bodies and they're our organs, and like people really need to be informed, you know, that's really important to me. And then I think that, you know, what you brought up came about like symptoms, you know, I think that this is something that I struggle with all the time, because like when we're putting patients through cancer treatments and they have symptoms, we try so much to ask them, right, what's going on. But I think that we all use different words for certain things and how we're feeling. And, you know, and it's also, I know that sometimes patients, like they come in for their 20-minute slot and then they feel rushed, and it's, you know, you're trying to condense 3 weeks of stuff into a visit, and it's so hard. And, you know, what we try and do, I think what I try and do in my practice is I have a nurse practitioner and I have a couple of nurses that help me, and we try and like, we're all part of the team. If you're having symptoms, send me a MyChart message, you know, give us a call. It doesn't just have to be that 20-minute visit. We want to hear from you throughout your whole treatment cycle, and try and keep those lines of communication open. But yeah, it's hard.
Yeah, I wanted to speak to both of those points, if that's okay.
Sure.
Just first, as we were doing the Witness Project and Real Talk, and, you know, I only showed a few of the slides related to HPV, but we talked about cervical cancer and Pap tests. We started out with anatomy. We would start because, you know, again, women don't know. Many women have no idea about their reproductive organs and what is the cervix. Many women don't know. They've gone through years of getting Pap tests. They don't know what it's for. What are you looking for? What are you actually testing? You know, so that I think is really key just across the lifespan. It didn't matter across age groups, you know, that knowledge wasn't there for a good portion of the women we reached. So I just totally agree with that. We need to talk more about, you know, because you can't see it, right? So it's like, you know, so we don't think about it. And I think that's really important to normalize that and do more education around women's or people's bodies, you know, those who have have a uterus and a cervix and so on. So I think that's key. But I also just want to reiterate the point around communication that Kimberly and Laura are talking about, you know, in those focus groups. That was such a huge piece of it. That said, and again, remember, we're dealing with parents who were already the HPV vaccine it was recommended, or their doctor already brought it up, the provider already brought it up, and they said, oh, I'll wait, or they just said no. And that we wanted, a lot of those parents in those groups talked about wanting to have more time, wanting to be able to, first of all, they felt like their doctors weren't necessarily great at answering their questions and giving them information, but even wanting to walk away with brochures. Can we have something that I can read, and can I take it with me and come back and then we can discuss it? They wanted the time. I know a lot of what we recommend and some of best practice, you know, is this then presumptive announcement, like just tell people, you know, you're going to vaccinate, right? And kind of, or sandwich it in between other vaccines. But there's going to be some folks still that for whom they're going to want more information. You have to be prepared to kind of go in depth, especially when you're talking about communities that have, again, mistrust and have negative experiences with healthcare systems. You can't just try to slip it in there and try to move forward. That's not going to work, and it's going to lead to more mistrust. So I just want to reiterate just what people are saying. That definitely was a huge issue for our parents. But at the end of each of those focus groups, we asked, hey, you know, what could get you to change your mind? And only a few people said they just would. There's some people just adamant. They're just like, no, I'm not getting my child vaccinated. I'm not doing this. Most of the people said, if my doctor would talk to me, if I could have more information and more of a dialogue with my healthcare provider, they felt like it was possible. They could be moved. They could be swayed.
That's interesting. And I think most of our patients probably would fall into that line, that the more you know, the better decisions that you can make. And just to mind the chat, someone is putting in information references from the American Cancer Society. So thank you for that. And just to the producers of the meeting, hopefully the chat questions can be posed in a way that others can read them, but we are asking, there's a few that I can see posed to Dr. Thompson about how we can get in touch with you specifically about the Witness Project, and that will probably be shared, I'm sure, at the end of the meeting. So thank you for that. Olivia, just chatting about the work that you do in Northeast Ohio, which is comprised of about 20 counties, from very urban populations to very rural populations. It may stretch this a little bit, but can you tell us some unique challenges or faced by rural and remote communities when it comes to cancer prevention and specifically screenings, if that's in your wheelhouse?
Yeah, absolutely. So I think a large part of the difficulties in maintaining cervical cancer screening throughout your entire lifetime is access to care and time available for care. Um, Again, just to reiterate, I worked a lot with the Hispanic community in Cleveland. I do speak Spanish, so we did a bunch of community engagement studio sessions working on identifying what makes it difficult to get a cervical cancer screening. And I think the large issues pointed out to me were that number one, like systemic barriers, scheduling. It's really difficult to schedule your preventative care if you work 9 to 5, if you work second shift, if you are an essential worker, only available on the weekends. And I think especially in rural communities where you have fewer areas for healthcare availability, fewer, you have to drive further distances to access your care, it becomes even more difficult. And so through these community engagement studio sessions, we gathered so much valuable information, and we were able to basically make some recommendations, especially through the Metro Health system, is that, like, in order to increase these screenings, like, first you have education is so huge. So there are a lot of community organizations that work to expand cervical cancer screening, but also breast cancer. I do want to shout out the Breast Amigas program through the Metro Health system. They do incredible work. And a lot of healthcare systems do pop-up events and mobile clinics. So adapting those to be able to allow cervical cancer screening in some way, like there are vans that can be like closed for privacy where pap tests can occur, or here's HPV vaccine station. Those are great ways in rural communities and with people that don't have time to take off work and go at 1 p.m. to get a cervical cancer screening. This is a way that they can access their cervical cancer screening so that they can stay on top of their healthcare. And yeah, so that's kind of where we were with the greater Cleveland area, because again, there are so many different types of areas that we're working with. Right. So I think a huge part of it is community engagement, going out to people instead of asking them to come in, and educating them, like, work on getting your cervical cancer screening every 3 years, or even like the work that we're doing to provide at-home tests that you can take every year, just to ensure. And these are mostly HPV tests only, like you're not able to get cervical cancer screening exactly from it, but making sure that you don't have HPV year to year is a great way to ensure that you're not getting cervical cancer year to year. So there are just ways that you can adapt cervical cancer screening based upon where you are, that I think a lot more healthcare systems should look into, because we can eradicate cervical cancer. And I don't think a lot of people see it as a priority.
I just want to follow up, because I have heard of the at-home option. I think that we have made progress in areas like colorectal cancer, where there's at-home fit kits and Cologuard. Could you speak a little bit about what that is, and possibly how we can get access to the sort of at-home opportunities or kits?
Yeah, absolutely. So this is a super exciting project that we're working on. So it is almost exactly like the colon fit test, like you mentioned, where there are self swabs that you can do in the privacy of your own home for HPV. I don't believe that there is a cervical cancer specific option at this time. And I know that with Metro Health, we're working on the at-home HPV tests right now. But I think this is a really great way, especially year to year, in between your like 3-year cervical like pap tests. This is a great way to kind of keep aware of what's going on in your body. And you also don't have to go to a provider every single year if you're nervous about cervical cancer, if it runs in your family, something like that, to stay on top of your health. I think there are a lot of ways that it could be adapted to a lot of different health systems. I think it's really just seeing that as an option. I don't know if it can be purchased commercially, unfortunately, but I think if more health systems provided that as an option, it would be a huge way to reduce incidence of cervical cancer. Because if you notice some like abnormalities in your test, then you could maybe schedule a pap test to be sure. So I think being able to allow people with a cervix to take control of their own health is to offer these at-home tests and we should be able to adapt them for a variety of as many different conditions as we can. I think they're amazing. So I'm really looking forward to being able to publish this research because we're getting some good data, but I unfortunately just don't have the data quite yet. So
I was just going to touch on that a little bit because I think this home testing is a really exciting space. You know, we know that the vast majority of cervical cancers are HPV driven. There are some that are not, but most are. And so, you know, over the last couple of years, the way that we've looked at cervical cancer screening with pap tests and doing HPV has actually kind of evolved to be in, you know, we generally do in women patients less than 30 pap tests alone, and then over 30 co-testing, but also HPV testing alone is an option every 5 years. So like that is an option. And I think the one thing that like with these at-home tests is there's nothing that's FDA approved yet. And you can buy them commercially. So, I mean, many of them are like $50, $60, which is obviously a barrier. But I think that like in the studies that have been done, they have shown pretty good correlation between a provider HPV swab and a patient HPV swab results. So what we kind of understand is that patients are probably able to do this as good maybe as we can. Sure, you're not getting the actual cytology, you're not getting the cells on a smear, but we know that if you have high risk HPV on your cervix or in your vagina, you are at risk for cervical cancer, you're at risk for high grade dysplasia. So I think that this is probably a really good way to capture more patients for screening, but there's also for a lot of other groups, not only just in rural areas, but patients with disabilities, you know, who can't come in and have a vaginal exam. It's too uncomfortable for them. This is an exciting way to be able to screen them, you know, in patients that, you know, are transgender patients and patients that having a vaginal exam is not congruent with and kind of triggering for them based on experiences. Like I think that this provides patients control over their own care. So I'm excited about this space. I think that there's a lot that can be done. And I'm really excited about your research, Olivia. I can't wait to see that published. I'd love to see it.
I think it's great, especially as it relates to access. I want to shift and stay a little bit in the space of screening. It really is important to me, important to all the work that we did. And Olivia, you mentioned screening around the recommendation around every 3 years. So there's a question in the chat and it reads, what is the preferred guideline for screening for women over 65? There may be some discrepancies in just understanding that, and wondered if Dr. Thompson or Dr. Chambers, if you could speak to that.
I'll let Dr. Chambers take that.
Yeah, sure. So what we traditionally have done is in women that have had adequate screening and haven't had abnormal pap smears, that 65 has sort of been like when it's okay to stop. But we know that, you know, there's a lot of different ways that can be defined, and what is adequate screening, and then does a patient think adequate is coming in every 10 years? You know, there's a lot there.
Sure.
And so what's kind of more contemporary is we can go up till the kind of guidelines support is like going up to 74 if you think that someone has at least a 10-year life expectancy. So, in my practice, obviously I see a group of women that obviously have a history of dysplasia or cancer. So, I usually am papping and doing cervical cancer screening beyond that. But I think that, kind of the cutoffs of, stop at 65 is probably going to miss some patients.
Sure. Okay.
Yeah, I wouldn't, oh, sorry, if anyone. I wanted to jump in. I know a lot of women that I talked to were actually over the age of 65 and still wanted to receive their pap test, and they were refused. And I think that having that hard cutoff at 65 is a lot of times just like difficult to move past, because a lot of providers just are like, oh, we don't need to get a pap test, you're 66, like blah blah blah. But I think there's probably a small number of cervical cancer diagnoses being missed. So I think that's also something to consider, is if you want to play it safe, get your pap tests for sure. And I think providers should allow that.
Yeah, and discouraging to no end if you're that patient.
Yeah, just there's a space there for, just to piggyback, was going to say something very similar. And there's, I think, a great need, as with all types of cancer screenings and care, shared decision making, right? It should be the result. It should be a decision made in collaboration, in partnership with one's physician and provider. Every person is different. Everybody has different, circumstances. So that communication piece just remains, key.
Excellent. And just staying in the same space with access, there is a link in the chat for people to be able to get access to screenings with BCCP. That is in Ohio. I'm unclear if that's in other states, if others are joining us. Staying in the realm of access, could you, all of you, speak to more of our marginalized communities, and in particular, people who are unhoused or housing insecure? How do we address that? What does that look like? Obviously, barriers in terms of housing, but just wanted to open up there.
I think I can kind of go back to what I mentioned before, is the importance of being able to adapt free pop-up events and mobile clinics for cervical cancer screening. I mean, if you are housing insecure, identifying as homeless, it's probably not a priority to get preventive care. And that's exactly what cervical cancer is most of the time. So I think being able to make those changes so that providers can go out to communities with housing insecure, low income, maybe rural communities as well, I think that would greatly reduce incidence.
I would also say education, making sure that they understand the importance of the screening. Because I think if you've gone through life and you haven't had a bad screening, or in some instances, like, and I've shared before, when I was in my early 20s and I was underinsured, I went to Planned Parenthood and got my screening done. I was told I had an abnormal screening, but I was never told I had HPV or I had different things. And so you think you're fine. And HPV will hang out sometimes with you and you don't even know that you have it and no one is telling you. So it's all about education so that they know that this is connected to these HPV related cancers. I think being more informed helps you. And I was just I know we talked about vaccination a little bit ago, but just to bring this home and bring this up, I'm a mom of two. When it was time for my son to be vaccinated, the pediatrician asked me, did I want him to have an HPV vaccination? I said, is it necessary? This is before I was diagnosed with cervical cancer. She said, not really. I mean, if you want to get it done. So not until I was diagnosed with cervical cancer, I was researching and trying to find out. I went and I was looking on Survivor, literally, and I saw HPV and I went to my paperwork and was like, oh, I had this. And then that's what made me realize that as much as I love my pediatrician, I feel like she almost failed me because she never told me. She didn't explain to me. And so that's why I say education a lot, because if we're not informed, we can't make informed decisions. So that's, if you do a pop-up event and you're not explaining, hey, getting this screening could be life or death for you. If you're not explaining that this could be connected to a cancer, then they may not do it because it's not important. So we have to provide that information along with everything else, along with the science.
Yeah.
It's providing that basic information.
Agreed. And maybe part of the pop-up are pop-up vaccination clinics, not just pop-up PAP clinics as well. Yeah.
Yeah, and I would like to emphasize that HPV is not just a women's disease. Men can get HPV and spread it to women. So it is essential that everybody, no matter how they identify their gender, needs to get the HPV vaccine, because I mean, it can, everyone, it's not, it doesn't care who gets, how it spreads. HPV, anyone can get HPV.
Sure. Thank you for that. And someone did put in the chat the Michigan program that can cover breast and cervical cancer screening. So thank you for that. Just staying in line with sort of the screening information. What strategies, and Dr. Thompson shared some that she took part in, do you recommend for increasing access to screenings? Olivia, you mentioned that, and just wanted to know, Dr. Chambers, from your area and locale, if you have anything to share.
You know, I think in our area, we take care of, you know, women in kind of metropolitan Columbus and these areas, but we also do take care of women from kind of within quite a radius of Ohio. And so there is a number of outreach programs through the James that are trying to kind of expand access. But also just trying to expand education as well. We have a number of partnerships with OBGYNs in more rural areas, and kind of getting out the message of like how important it is to educate and screen and that type of thing. And I think that the James has done an absolutely amazing job in trying to kind of make those collaborations outside of our immediate locale to try and improve access.
Thank you for that. Oh, Olivia, I'm sorry.
I think education about different programs is essential as well. I know somebody linked BCCP in the chat. There are so many people, at least in Metro Health, signed up for BCCP, and I don't think enough people know about it. So being able to get the news out about programs where you can get that allow you to get your breast and cervical cancer screening is also a huge factor.
And someone did add into the chat, in Ohio, many family planning and Title, I think 10 clinics are BCCP providers. So you're right, Olivia, there's a lot of resources that I think the community can sort of tap into there. Just leading to someone who has a diagnosis and treatment and then ultimately into survivorship. And I want to just pose this question to Kim. How can we continue to meet the unique needs of cervical cancer survivors and ensure they get the support and care that they need?
Oh, that's a big question. I think just showing that sometimes it's as small as just showing up and showing that you're there. We're not looking for all the answers as far as like that you have all the answers, but just saying like, hey, I'm here. I love when you said wheelhouse. I was like, I'm going to snatch that and take that for the rest of the year. But you know, whatever is in your wheelhouse that you can provide, I think that's it. Sometimes I think we're looking at trying to fit everything into one box, but that's okay. If that's not your area, just what can you do in your wheelhouse? The biggest thing that we look at the most in Survivor is what kind of information that we can provide to our community of patient advocates so that they can go out and spread that information. And so I know I keep saying education because that's the biggest thing that we look at, because the only way that we can be effective patient advocates is by being informed. As long as we're informed, we can be effective. When we're not informed, we can't be effective. When I was first diagnosed with cervical cancer, I didn't talk about it a lot because I didn't know a lot. But I just wanted to tell people, hey, I got it. You may want to go get checked, but the more I learn, the more I can say and the more comfortable I am. So I think as like American Cancer Society and even us as survivors, which of course we're partners, but partnering with even physicians and to share information so it allows us, I mean, we talk about this all the time, and even during Cervical Cancer Awareness Month, which is in January, it's sharing that information so that even people that are not diagnosed with cervical cancer, so that they have that information so that they can share it with their communities. I usually say, listen, even if you share this information with your sister, your cousin, your friend, a lot of times that information, once it's shared, they are taking that information and they're utilizing it elsewhere. They may not tell you, but they're taking that information, and that information has wings.
That's great. I'm curious to know, because education, again, thematic throughout all of this conversation, what are some of the biggest myths maybe you had personally, and this could be anyone, or some of the patients that you've seen that you have to sort of consistently sort of redirect and provide more, more correct information around?
I think with cervical cancer, that they're saying things like you had to be promiscuous, you had to have had sex with a whole bunch of people. You could have sex with one person that was infected. My ex-husband said, oh, well, you must have did something. This is a dirty person disease. It's like, well, okay, listen, So it's learning that you didn't do anything wrong. Learning that the majority of people that have had sex have HPV. You just have the high risk portion of HPV. So giving that education. Even with the vaccine, that if their child receives the vaccine, they're gonna be sexually active, or they're gonna start having sex. It's like they're 9, so it's those things of trying to explain and make sure that they understand, because those are some of the myths that come along with cervical cancer, or any of the, as Miss Olivia said, the HPV related cancers. And because understanding, like trying to explain that it's not just because especially with people of color, when it comes to vaccines, we become very nervous. That's why it was a slow uptick when it came to COVID vaccines. Like, I'm not putting that in my body. But explaining to them that HPV vaccination is cancer prevention. That is the words that we utilize. When you utilize that, they're like, oh, wait a minute. And what I tend to say, like when I'm talking to people, if there was a vaccine for breast cancer, we'd all get it. This is the one cancer that was it 6 cancers that the vaccine can fight against. So when you put it in layman's terms, I think a lot of times when people are talking, they're using those 15-letter words and nobody knows what's going on, and we're sitting there, never mind, don't worry about it. Once you break it down, like it's cancer prevention, you're helping, you're giving your child something that even if you gave them a 401k, it couldn't prevent. So those are the type of things that I think when talking in layman's terms, because those are the things that makes people a little nervous with those myths.
Yeah, absolutely.
Yeah, everything you said, I totally agree with. And I think one of the things that I notice in my practice is a lot of patients think that if they have a speculum exam or a pelvic exam, that equals cervical cancer screening. So many patients will think, oh, I went into the emergency room and I had discharge and I got a speculum exam, so that's being screened and I'm okay. I get this all the time. Like when patients are like, oh yeah, well, when was your last PAP? Oh, it was in the ER this time. And so that's something that I really try and educate is like, a cervical cancer screening is very different than just having a speculum exam for discharge or whatever complaint you may have had. But I find that is something that I have to talk about a lot, Because I think many women don't know the difference. And then they're thinking, oh, I had a speculum exam, so I don't need to go for my
Right.
screening.
Oh no, that's fascinating. I wouldn't
Yeah.
have thought about that, but
Yeah.
true. Anyone else around myths? Dr. Thompson, did you? Oh, okay.
Well, I wanted to actually mention this, kind of moving a little bit away from myths because I know we're coming to
Sure.
the end of time. I
Sure.
actually, when I was kind of preparing and thinking about this presentation, I came across an article, and I think Megan Landry shared it in the chat. It's very recent this year. Racial and ethnic disparities in cervical cancer stage of diagnosis, the mediating effects of neighborhood level socioeconomic deprivation, right? And I just wanted to kind of share that as a reminder, because we're talking a lot about educating individual patients. We're talking a lot about patient provider education, but cervical cancer disparities and equity, like other types of cancers, right? It takes place in a larger context. So I just wanted to kind of share that as a reminder that, we need to think about, when we think about health equity, we can also, that's adjacent to health justice, right? So we have to think about the conditions and the neighborhoods and environments in which people live. And we're still learning so much about how things beyond individual level experience or care impact health and impact cancer, right? In terms of at a neighborhood level, what the home ownership or the quality of schools, all these things kind of play a role and kind of take all these different pathways that then lead to these health disparities. So, I just want to encourage us to kind of keep those factors in mind as well.
Hugely important, and all determinants of sort of equitable health outcomes. We are close to time, so I just didn't know if anyone had any sort of wrap up takeaways. I think ending on what Dr. Thompson mentioned about other areas of focus is important. Okay, well, so appreciative to everyone, to Kimberly, to Dr. Chambers, Olivia, and Dr. Thompson for this wonderful conversation around screening and outreach efforts. It's hugely important, and we appreciate your time, and hopefully the participants got the information that they need and their questions answered. Again, people are monitoring the chat, but thank you so much for your time.
Thank you.
Thank you so much, Chesley and panelists. We are so grateful for all that you shared and the honest and direct dialogue that you had with us this morning. It's incredibly powerful. And I think you can see from the chat and the Q&A that there's a lot of conversation we've sparked. So that is our mission, and we're excited about it. Thank you. Let's move then to our next presentation. But before that, we do have a poll question that we would like to bring up. So we'll ask our producers to put the poll question up on the screen. Our question for you now is, what do you observe as the biggest barrier when it comes to cervical cancer screening? It is multiple choice. Feel free to scroll up, scroll down, make multiple selections. And when you're completed that, please go to the bottom right and hit the submit button. We'll give you just a moment to make your selections before I introduce our next speaker. All right, while you're finishing that up, I will begin an introduction here. Our next speaker is Erin Fahey. Erin is the Manager of Quality Transformation Department at St. Elizabeth Physicians, where she leads the organization in providing the highest level of quality patient care to Northern Kentucky and Southeastern Indiana. She earned her bachelor's degree in business from Indiana University in Bloomington and her bachelor's degree in nursing from the University of Louisville. Since then, Erin has gained over 10 years of healthcare experience as a registered nurse in the intensive care unit, care management, ambulatory operations, and quality improvement. Erin is passionate about leveraging EHR functionality, data analysis, and streamlined processes to ensure patients are appropriately identified and screened and navigated through the cancer screening process. Erin, welcome this morning. We're so glad to have you with us. I'll turn it over to you.
Thank you so much, Deb. I appreciate it. I'm very excited to be here and appreciate this opportunity. I'm basically here representing some of the work that we did at St. Elizabeth Physicians. Last year during 2022, this was the first year that cervical cancer screening was on our strategic quality objectives for the organization. So this had never really been looked at from a quality improvement perspective. So we were excited to jump in and take a look. So as you can see here, we were very excited to see some positive results by the end of 2022. We had actually increased our screening rates for cervical cancer screening from 33.1% at the end of 2021 to 58.3% at the end of 2022. So our goal then and our goal this year again is 60%, and we're well on our way to getting there. So hopefully we'll cross that threshold this year. From our perspective, we really looked at this from a system-wide approach, looking at all pieces of the puzzle, starting from patient identification all the way through ordering and completing the test to results management and to reporting. So some of those things we were able to make headway on during the year last year, and I've highlighted some of those here. So as you can see, patient identification was really the biggest opportunity for us from the get-go. And we really hadn't done a very good job of identifying patients within our EHR system, which is Epic, especially not compared to some of our other cancer screening opportunities that we had. So first we dug into the fact that a lot of our patients, we were not really documenting their hysterectomy history very well. So as we know, with a hysterectomy, sometimes there's the cervix is still left intact, sometimes it is not. But we really weren't classifying that based on the type of hysterectomy that our patients had had. So we made quite a few documentation enhancements and did some other updates to ensure that we had a good hysterectomy history for our patients. Having this in place really allowed us then to implement other EHR tools based off of that more accurate history. So we were able to make updates to our health maintenance topic for cervical cancer screening, ensuring that we were identifying the right patients, excluding the right patients, and also updated our rescreen timeframe. So before we got started on this project, everyone was due every 3 years, regardless of the type of screening that they had completed. We took this a step further and implemented a best practice advisory, or BPA, for cervical cancer screening, so that we were really triggering our associates in the practices and our providers to identify patients to ensure that they were then having that conversation and hopefully getting that screening completed. So that was a big bulk of our work, and we were able to really improve our processes around patient identification. Throughout this process, we identified the fact that we do have a good chunk of our population who goes to a different facility external to ours to complete their cervical cancer screenings. And we were just doing an okay job of capturing those results and getting those into our patients' charts so that we had that full accurate record of what screenings they had completed. So we improved some of our interoperability with our CE, stands for Care Everywhere, results and that integration we had with external organizations. We also created a new order process. So this was an external results request order that basically allows our associates in the practices and our providers to address the need for cervical cancer screening with patients when they share that they have completed that screening externally to our organization. The associate or the provider, then they can just enter an order into the system. That order comes to a central team, and the central team manages the outreach to get those results sent over to us and then abstract those into the patient's chart. So really trying to streamline and standardize that process and take that work off of the practices so that we can ensure we get those results in the patient's chart. We also focused on ordering and created a standard age-based order set, again, to try to streamline the ordering process for this screening. We focused especially on our 30 to 65-year-old patients and determined what that standard order would be. For our organization at this point in time, co-testing was that preferred test. So we built that into the order set really to make it easy for our providers to order the right tests and ensure that gets completed. And then finally, we did a lot of work around our reporting. So ensuring that we have basically a custom built metric. So ensuring that that logic and that build was in line with our HEDIS and NQF guidelines, and also making sure that we had the appropriate denominator inclusion and exclusion criteria, as well as our numerator inclusion criteria. So a lot of work went into that to make sure that we are reporting accurate data. I'm a big believer in that knowing where we stand accurately is really important to allow us to really build off of that and know where we have opportunities and where we need to focus our efforts. So we did a lot of work around that last year. So this year, and kind of looking forward a bit, We're continuing to work on some of these things and really refine some of the processes that we put in place. We're focusing on underserved patient populations, so specifically around those who are uninsured and have difficulty affording care, as well as one thing we identified last year was patients who are wheelchair bound. In our primary care practices, we don't have the ability to support a safe transfer for those patients due to the exam tables not lifting and lowering. So we're working on building basically a decision tree question within our scheduling to be able to identify those patients and ensure that they are scheduled with our women's health department so that we can facilitate that safe transfer. We really want to ensure that we're identifying these barriers that patients are facing, usually compounding on other barriers, so that we can try to break those down and make it a bit easier for them to complete their screening. I also have central results management listed here. And so this is really mimicking some of the other central results management processes that we do have in place for other types of screenings. And this would be focusing on our primary care completed PAPs. What we found during our project was that when a PAP or a screening in general is completed within our primary care setting, those providers aren't as used to, just by sheer volume, managing those types of results. And so our women's health department actually said, we got feedback that they were getting inappropriate referrals, et cetera. So we're focusing on bringing those results to a central team to ensure that we have the appropriate follow-up for patients and that process is standardized so that we can see better referrals and better follow-up for those patients. So we're excited to see where the future comes. And like I said, we're continuing to work towards that goal of 60% and really try to focus at the organizational level with our EHR tools and also get down to the patient level and help break down some of those barriers. Thank you so much for your time today.
Erin, thank you so much. Over 25% increase is tremendous. Congratulations to St. Elizabeth Physicians, and we have every confidence that you'll reach 60%. This has been very exciting, so thank you.
Thank you, Deb. Appreciate it.
Absolutely. Our next speaker this morning is Leo Almeida. Leo is the Government Relations Director for the American Cancer Society Cancer Action Network. He leads the volunteers and staff across the state of Ohio through campaigns to achieve progress on evidence-based policy and legislative solutions designed to eliminate cancer as a major health barrier. Leo has worked for over a decade on all sides of policy, politics, and legislation. Most recently, he served as a senior policy associate for the Nature Conservancy in Ohio. And before that, Leo worked for the Ohio legislature, where he started a legislative fellow and rose to become a senior legislative aide to the Senate Minority Leader. He has also experience with local and statewide political campaigns. Leo holds a Bachelor's of Ethnic Studies from Bowling Green State University, and we are so pleased to have you with us today, Leo. Welcome.
Thanks, Deb, and good morning, everyone. Not sure why I have to be the one who follows such a powerful panel. That was a really great discussion and a great segue into what I'm going to be talking about, actually, with the Breast and Cervical Cancer Project. So we can go to the next slide. For those of you who aren't too familiar with ACS-CAN, for over 20 years, the American Cancer Society Cancer Action Network has made cancer a top priority for policymakers at every level of government and had measurable impact on reducing cancer's toll on individuals and families nationwide. ACS-CAN empowers volunteers across the country to make their voices heard, to influence evidence-based public policy change that saves lives. We believe everyone should have a fair and just opportunity to prevent, find, treat, and survive cancer. ACS-CAN continues to be a strong advocate for breast and cervical cancer funding in Congress and in state legislatures across the country. You can go to the next slide. At the federal level, we advocate for funding for the National Breast and Cervical Cancer Early Detection Program. This is an important program that has provided over 15.7 million screenings screening exams to more than 6.1 million people since 1991. So overall, a very successful and much needed program. During the current debate over the federal budget, we are urging Congress to provide $230 million in FY24 for this program. Our hope is that that funding will allow the program to continue providing the services that are needed. And again, we do this by utilizing our volunteer network and other partners to advocate for this funding by messaging elected officials, by going to DC to advocate on the Hill, and utilizing our social media tools as well. You can go to the next slide. So switching gears to our state advocacy efforts. I'd like to share some highlights for Ohio and West Virginia. In Ohio, the state legislature passes a biennial budget every 2 years, which is when we advocate, again, with our volunteers to advance funding for the Ohio Breast and Cervical Cancer Project, also known as BCCP, and appreciate that so many of you have been highlighting BCCP in the chat since the panel discussion and with the question and answer session. So this year's budget is currently being debated. We have to pass the budget in Ohio by June 30th. So it can be signed by the governor that day and then officially go into effect on July 1st. The budget bill that we're currently working on is in the Ohio Senate right now, and it does include exactly what we want to see for BCCP, which is a level funding at $1.1 million in FY24, and then a slight increase to $1.2 million in FY25. And I've been spending a lot of time at the State House focused on the budget, and everyone I talk to is very supportive of this. So we're feeling really confident that this is what we will end up with. The final budget will look like this. BCCP, as many of you know, is a critical safety net program that provides free mammograms, cervical exams, and other prevention services to more than 7,000 low-income Ohioans each year. Similarly, my counterpart in West Virginia also advocates for their BCCP, and again utilizes their volunteers to advocate for funding. The West Virginia Breast and Cervical Cancer Screening Program works with over 300 providers statewide to ensure eligible women receive the services they need. We're happy to report that West Virginia lawmakers recently passed their annual budget, and it included level funding at $400,000 for their program as well. This amount has been included in the state budget in previous years, and of course ACS will continue to educate lawmakers on the need for continued funding in the future as they discuss other budgetary needs. So thank you for allowing me to be with you today and just give some highlights on how we advocate for the funding for these really critical programs.
Leo, thank you so much for being with us today. We certainly do appreciate your commentary. Our next speaker is Courtney Van Oord. We are so excited that Courtney is joining us today. She is the program manager for the ACS National Roundtable on Cervical Cancer. Courtney has worked at ACS for the better part of a decade. She came to the roundtable from the West Region's Cancer Control Team, where she served as the Strategic Partnership Manager for Alaska. In her role there, Courtney played an integral part in bringing HPV vaccination and colorectal screening awareness to Alaskans across all regions of the state, both tribal and non-tribal. She chaired the Alaska Cancer Partnership's HPV vaccination work group, as well as the cancer detection work group. In addition to her work with ACS, Courtney held a contract with the state of Alaska's Ladies First program, where she convened partners and worked with providers to identify and enroll eligible women in the program, as well as help reduce barriers to completing breast and cervical cancer screenings. Since joining the roundtable, Courtney has utilized her work in the field to help bring awareness to health disparities experienced in rural areas. She has had the privilege of assisting with the formation and the launch of the new National Roundtable on Cervical Cancer. Courtney, welcome.
Thank you very much. We can go to the next slide. got a lot of wonderful people to follow up, but I'm going to wrap this up here with just introducing the ACS, the American Cancer Society National Roundtable on Cervical Cancer, also called the NRTCC, the ACS NRTCC. So next slide. So we launched the roundtable in response. Our call to actions were the World Health Organization launched a global campaign saying 90% of girls should be fully vaccinated with HPV vaccine by 15, 70% of women screened by 35, and again by 45, and then 90% of women with cervical disease receive necessary treatment for pre-cancer treated cancer treatment, whatever that is. In addition to that, President Biden relaunched the Cancer Moonshot, and the Cancer Panel report called out for the need for a roundtable, and so we enthusiastically accepted the charge. And the report not only calls for the roundtable to be formed, but it called for prioritizing equitable access to prevention, screening and early detection and diagnosis of cancer, and a strong focus on health equity. So, next slide, please. So what is a roundtable? The ACS Roundtable is a coalition of organizations dedicated to a shared vision of giving all people a fair and just opportunity to prevent and survive cancer. Next. So why use the roundtables? As we know, like when you work in a group, you can address more than you do as a solo person. So some barriers that challenge some, we can work together and we can break down those barriers. We're a recommended and proven model that tackles both longstanding and emerging issues in cancer. And by having ACS lead these roundtables, we have staff that are able to lead and support to really convene these organizations. And drive that collaboration. Next slide. So through this, we can achieve, I mean, what can't we achieve by having a group of diverse stakeholders? But we're able to establish national priorities across the cancer continuum, catalyze coordinated policy and patient care solutions, build evidence-based strategies and translate them into practice, and leverage knowledge and experience that inform the reduction of health disparities. Next, and just going to go into our leadership here. So these are our chairs for this first, their term is this first year, but they're going to be renewing. We've got Deb Arundel, who works in health policy at the American Sexual Health Association. And then we have Dr. Akiva Novetsky, who is with Westchester Medical Center in New York. And then our very own Dr. Debbie Saslow. She represents the American Cancer Society, but she's also a subject matter expert. Next. And so our steering committee were really selected with intention to cultivate diversity and inclusion in the roundtable. So we sought out members who work well together, who have expertise from across the cancer continuum. We didn't just want it to be prevention. We also need to recognize that there is the treatment piece that needs to be addressed. We really, really want to center everything we do in health equity. So we wanted to make sure that that our committee is our champions of health equity. We have some lived experience on the committees. Kim, you might see there's Tamika there. She's the founder of Survivor. And then we work with those, with people that are in those populations. So we've got representation from Alaska to Florida, all four corners of the United States, really. And then with underserved populations, and so forth. So we really were strategic in selecting our steering committee. Next. And so this is just the ACS staff. So as I said, Debbie Saslow. Shelley is also a lived experience expert. She is a survivor herself. She's our director. And then Jane Gerndt is program manager of, we have the primary HPV screening initiative. So as we were talking about earlier, like that, moving from that pap smear, but to being able to do the primary HPV testing. Jane is working really in that space. And then I am the other program manager for the roundtable. Next. So our vision is a world without cervical cancer. Pretty straightforward, but it's one of those that, you know, cervical cancer was once the most common cause of cancer death for American women. And it's dropped a lot, and we've seen, you know, with HPV vaccination and with the screening abilities, this is something that we can eliminate. So next slide. So our mission of the Roundtable is, the Roundtable is a national coalition of member organizations who, through a collective action, will tackle disparities in cervical cancer prevention, screening, and treatment in order to eliminate cervical cancer and reduce the harms caused by the disease. Next. So we don't need to go over all the data, we've seen it in this, but approximately half of all the cervical cancers diagnosed in the US are in women who are never screened, and an additional 10% are among women not screened within the past 5 years. There's significant disparities, as we've seen in this webinar today, that need to be addressed, and it's almost entirely preventable. So it's there's no reason that women and people with the cervix should be dying from this disease. Next. So since, as I said, we're centering everything around health equity, and so we believe that every person should have a fair and just opportunity to prevent, find, treat, and survive cervical cancer. And by we say every person, we say women and people with cervix, and that's simply because, as we were talking about, as you heard in the panel, oftentimes women don't know they have a cervix or don't know what their cervix is. And then you've got the queer population who know their anatomy and need to be addressed in this. So we do say women and people with a cervix. Next slide, please. So to center health equity, we will ground our work in data and context, creating tailored solutions. We'll focus on policy and system changes in addition to programs and services. We will listen to and act in concert with the community and share decision-making power with community and institutional leaders, and build equity and leadership and accountability. So this is just where we're at. We launched, I'll address it in the following slides, but in October, we're in the year 1 to 2 phase right now, and then we'll get to that 3. But really we're in that point of, we've launched the website, we had our event, now we're working on building the Roundtable membership, activating work groups. Next slide. So our official launch was October 24th, 2022, and we were able to launch from the White House. You can go to the next slide. Dr. Biden actually had us as her guests, and we launched the same day as the Breast Cancer Roundtable. And then we followed up the launch with educational session for partners and organizations. And we started to do the work that day. We launched, and that day and the next day we were in 12 hours of meetings starting to build things. So a lot's been done. Next slide, please. And so we're really focusing on that community input right now, because we need to understand the needs of the community in order to address those. So we can go to the next slide. We did some formative research to start off. That's what we've been focusing on since October, really. And we worked with the same people that work with the President's Cancer Panel and did some nationwide research. So we did 33 key informant interviews, 7 focus groups with 19 different participants in there, community conversation groups that were led by community specialists, like the reflective of the community. And then we sent out a survey that we received 531 responses from. And there's a lot of things like we've addressed on here, these barriers and things that we think we know, but it is really important when we have these target populations to hear from those populations as to what they need. So we had to challenge those assumptions, and really, we can go to the next slide. This is who was represented. So we had public health agencies, medical systems, everything from large to small, survivor, persons impacted by cervical cancer, so maybe a family member of a survivor. We've got queer population, insurance, everybody that we could reach. And then next slide. And the next 2 slides really just go over what the demographics of our response is. So you can see that it is a diverse group. This one, the community conversation groups, actually representing the BIPOC community largely. So that is great to see. And then if you go to the second slide there, just the survey demographics, you'll see. And no participant was required to declare their race or ethnicity, but they were allowed to select multiple categories. Excuse me. And so from this, next slide, we Yeah, thank you. The data were analyzed and common themes were established. And so the categories that we came up with for the 5 top areas that everybody really, that came out from everybody, is the need for provider education, the need for patient and consumer education, stigma, and then primary HPV and self-sampling prep. So moving from that cytology alone to that primary HPV, and as was discussed in the panel, that self-sampling where people are going to be able to do these samples at home, and really the preparation for that, because it's going to be a big undertaking, starting in offices, waiting for FDA approval, but trying to reach some of those rural populations, as it was discussed, some people with disabilities, and reaching that population. So that's a large work group there. And then also access. As we said, access to care is a big issue. So these are our 5 work groups that we're starting with, and we are in the process right now. We've just secured the work group leads. And so those leads, there's 2 leads for each. And those leads are really putting together their teams. And then outside of that, those teams of 10 to 12 people representing different organizations, we will have our larger group of organizations that are able to weigh in on the discussions and whatnot. Next slide, please.
Courtney, I am so sorry, but we are running so short on time. I apologize, but I do need to interrupt you. One thing we are going to do, because we greatly appreciate your comments and the work of the roundtable, is at the close of today's webinar, the landing page people will be taken to will be the roundtable for cervical cancer. So we're excited about that. But we do thank you so much for your comments. We are so grateful to have you with us today. And in that note, I will ask our producers to move us to our slide that shares what is coming up next. Thank you so much. You can see that we have another fantastic webinar planned for you in August. But first, we'd love to have your answer on one more pop-up, and that is, based on your observation among those you serve, which population groups face the greatest barriers to accessing cervical cancer screening services? Please make multiple selections as you feel it applies, and you'll see the submit button on the lower right. While you're making that selection, I will tell you that the QR code behind that pop-up question on the screen, you're welcome to scan with your phone. It will take you directly to the registration site for our August 24th forum on breast cancer across the cancer continuum and health equity. We are so grateful that you've been with us today. Let me just tell you a little bit of a detail, and that is that the CME certificate will be sent out in 2 weeks once you've completed the post-event survey. The survey will pop up at the close of today's webinar. And again, we will also link you to the National Roundtable for Cervical Cancer. So you'll be able to complete your survey and visit the Roundtable website in one smooth move. If you don't get the chance to fill out your survey at the close of today's webinar, we'll send it to you in the follow-up email. That follow-up email will also contain the recording of today's session and a link to that recording. Thank you so much for being with us. Thank you to all of our presenters and speakers and panelists for all of the amazing information that you've shared. This is an important conversation, and we're thrilled to be able to present it to you all today. We are so grateful for you joining us, taking the time out of your schedule, and for your commitment to fighting for a world without cancer. Thank you so much. We look forward to seeing you again in August. Have a wonderful summer.